Okay, thank you. So we'll change tack a little bit, but I think you'll see a common theme coming through all the presentations. I thought this was witty when I wrote it. I recently watched Forrest Gump again with my son, so Jenny and I goes together like peas and carrots. And I think sitting and standing are integrally linked, right? That there are two dominant postures in everything we do. So there has to be some interaction between these. As we mentioned, and Dr. Rempel clearly showed this has come across a lot, but what this slide is showing you is an interesting development this year that, many of you out there hear your employees or if you're an ergonomist, the workers that you're dealing with wanting standing workstations, sit-to-stand workstations. Well, there was a lawsuit in California where standing workers filed a court case to get sitting stations. So if standing's so good for us, why are the people who are standing wanting to sit down, right? So both sides. And I think that'll mix together very shortly. One of the things to keep in mind, many of you are coming from industries that have probably very strong policy related to lifting exposure. So that's on the right of this risk curve, right? So heavy lifting can be done for a very short period of time and can increase the risk of injury. Where what we're talking about now is sitting and standing, and that's a way to the left side. And depending on the injury model you believe, this is a J, and there's some studies that show you can get an increased risk from these low-level exposures, although that's debatable. And the thing to keep in mind is that blue graph in the center, that it's not an equal risk for equal exposure. To have an equal risk, you have to have much greater time in these low-level exposures. So that's the yellow line there showing it's almost the opposite of the risk shape. So high time, low-level exposure versus high exposure, low time. So difficult to look at is the message to take away from that. And I think that's some of the challenges around many of the issues we're talking about. It's not as simple at looking as somebody lifting 50 pounds or 25 kilos. It's how much are they sitting, how long are they sitting, how long are they standing, and this goes on for years, okay? I won't go through the hands up thing, but if we ask most people here, I think people would link sitting and low back pain. And we're going to expand on that in a second. And it rightfully comes to most people's minds. On the left of the screen was a document that was produced by the World Health Organization, and it identified that very bottom left corner that sitting for long duration is linked with low back pain. Okay. The UCLA Spine Center, if you can read that, it says sitting for long periods of time can be a major cause of back pain. And then our own Canadian Centre for Occupational Health and Safety has a line in there that static sitting postures are also linked to developing low back pain. Okay, I see lots of nodding heads. This is going to be, I think, the equivalent of Dr. Rempel's comment about is sitting really bad for you. This is the same plots just showing we have that exposure of time. If we think of our injury model, since 1970 to 2000, moderate level demand jobs have gone down. We've more than doubled sedentary occupations, showing the metabolic cost or percentage of jobs for light, sedentary, or moderate. Moderate's going down, and these sedentary and light demand jobs are going up. We spend a lot of time sitting, okay? At least 8 to 9 hours a day in total, or 76% of the day in Australia, studies showed. So we have the time, right? Unfortunately, the studies don't back up this. If you start looking into what is linking low back pain and sitting, it's not strong, unfortunately, because I'm like you. I think there's something there. It's just when you try and break it out, it doesn't fall out of the big studies that have been done. And I'll show you the disconnect in a second. But when you have an epidemiology study where you're looking at hundreds or thousands of people and trying to link sitting length of time or the sitting exposure with low back pain reporting, you can see I've underlined it here and this is a good study. This just came out in Premise International Musculoskeletal Disorder Conference this past summer. And it showed that objectively measured sitting time was not associated with low back pain. So this wasn't a survey asking people, they measured it. and had no association of low back pain. And this is representative of many of the big studies out there. I know, not good, right? So where's the disconnect? And I think when Dr. Robertson just showed her slide and the discomfort, right? You saw in the no training group, they had low back pain reporting in their discomfort scores. There are lots of studies like that. Small studies in a lab, I'll show you some of our own, that show in response to acute sitting, discomfort can increase. The other factors that link sitting and low back pain are things like biomechanical studies showing the loads in the joints and passive tissues go up in sitting compared to standing. There's laxity changes, right? We stretch them because we're sitting for a long period of time, and those persist over time. And the muscle response in sitting is different than in standing. So there's fundamental issues that are changing, but why is it not showing up in these big studies that are trying to link low back pain with sitting time? I'll come back to that. I'm not just going to leave you hanging. So let's change gears though. Standing, on the other hand, has very strong evidence that it causes low back pain and other musculoskeletal disorders. So one of Tom Waters from NIOSH's final papers showed that low back problems in standing develop over 50% of the work shift, so if they're standing a fair amount of time. Another study showing lower extremity muscle fatigue, even with regular rest breaks, persisted if you had 5 hours of standing exposure in a shift. And these were long, right? 55 minutes of standing in an hour. So these are the extreme ends of the case. Again, just showing that a lot of this is very recent, as is the metabolic studies that Dr. Rempel presented. This was another paper on standing from Premise this past summer, and it showed there's significant correlations between the amount of time spent standing and back pain and pain in the legs. Okay, so again, I think his comment of tapping the brakes is very true, even with musculoskeletal disorders now. So we have both sides of health, cardiovascular disease, and musculoskeletal disorders, both saying, standing isn't just a simple solution. Okay. So summarizing those two together, so are they linked with low back pain and musculoskeletal disorders? One of the key factors is it depends what you're looking at. So I call it quality. You can think of it as type of exposure or what they're doing within those exposures. And if it's constrained, so they're not allowed to move around a lot like the call center employees, then if they're standing consistently for over 30 minutes, the odds ratio or hazard ratio went up to over 2. Okay, so significant. Greater than 2 hours in females had an odds ratio of 2.9 and 1.6 for male, again, if it was constrained standing. And you can see that if the 17% there in the third bullet point are people that were free to move. Okay? So by simply giving people the freedom to move or make their own decisions, having control about their work can reduce the low back pain reporting. In contrast, sitting doesn't have a great number of studies that link this exposure of sitting and low back pain. I personally think there's something there. The mechanics underlying it show that there are potential injury pathways, but the big scale epi studies are not present. When we combine leisure and work, so very similar to the health aspects, you get a better relationship with low back pain as opposed to just occupational exposure time. And if you add driving in or some other factor, then it becomes a very strong predictor of low back pain. So just to be clear, I'm talking about office chairs sitting in an office environment, not strongly linked when you look at only occupational exposure. So why do we want to talk about mixing it then? Okay, standing's no better for health, we're hearing. Standing's probably worse for musculoskeletal disorders. But I think another common thread is from an ergonomics perspective, mixing exposures is powerful, right? You don't want too much of any one thing. So what we have here is just sitting and standing, and what it shows at the bottom of that graph is they're distinct postures. The postures that we are exposed to in sitting is very different than standing. So that sets up a perfect job rotation scenario where if we get people moving between these, it's changing exposure. Okay, and that's beneficial. We know that from all of our ergonomics background. And now it gets to the point of what ratio. I have no idea where the 28:2 came from. I would also like to know, I think it was one of those things that somebody said at some point and everybody jumped on. In Ontario, this is from our MSD prevention toolbox, parts 3A and B. And I'll tell you right up front, there are not many standards internationally around how long people should be exposed to sitting or standing. But we have some here in Ontario, and a risk factor is decided, or this is a potential risk if a worker's sitting more than 6 hours per day total, or if they stand for more than 4 hours without taking 2 steps in any direction. So the constrained idea. So that's pretty good. One of the other ones that pops up, if you look, is one out of the Netherlands. Very similar, more than 4 hours a day is a health risk, or 1 hour of continuous standing. Okay. And if anybody knows of other ones, I would love to hear from you. These are about the 2 biggest ones I've ever found. Okay, it's a little tangent, but to get you thinking about why sitting is not showing up and even standing. You all probably have lift strategies in place and policies about lifting. If I told you today to change them, just drop what you're doing and just say, is a worker lifting more than 4 hours? Then it's a risk. You'd all go, you're nuts, right? There's all kinds of evidence on it's the mass of load, the repetition of load, where the load's located on the floor, or if they have to bend down. So there's qualifiers of what that lifting is. Agreed? Where we're sitting right now is standing and sitting is we don't have any of those modifiers in there. It's not how often they're getting up. It's not the ratio between sitting and standing. It's not what they're doing in sitting, what postures they're in. We design workstations to try and mitigate some of the known risk factors, but we don't have guidelines that are addressing the same kind of factors we have for other musculoskeletal risk factors. Okay? And I think this is one of the issues, that if you even think of any of the ratios that have been proposed, does that mean I can, if we stick with a 3-to-1 ratio or something, does that mean I can stand consecutively for 2 hours and then sit for 6? Or do I have to mix those, and how do I mix those together? Okay, so some of our own work, I'll change, that's the big picture, and I'll show you some of our own work around low back pain and standing, because I think it's fascinating, actually. And what you're seeing there is an average pain response of what we call pain developers and non-pain developers. And we use a cutoff of about 10 on the same kind of analog scale that Dr. Robertson referred to. And that's just a rating by people to say what pain they're feeling at any point in time. And after about 30 or 45 minutes, they report significant back pain. Have to make the point that these are not low back pain cases that are seeing doctors or the clinical system for care. If you ask them up front if they had back pain during standing or had problems standing, they all say no. There's no differences on any clinical pre-screen. So these are your workers, these are your people. You will have a proportion of the population that just don't tolerate standing well. And there's been multiple studies that have picked up our model internationally, and it varies between about 40 and 70% of the population, okay, depending on the sample you take. So I kind of rough it out and say about half of people don't tolerate standing well. What's going on? Well, one of the things we found is they recruit muscles differently. I don't want to present a lot of data, but I think it's important to have some evidence. And what you can see here is co-contraction. So they're recruiting muscles together versus sequentially in non-pain developers. So how they're controlling their response to standing. And that's just the pain developers in red, and they're showing much higher levels of muscles turning on together. Is it important, you're asking? So what? You found this neat little academic model. We followed these people for 3 years, not a huge sample size, but what was important was 35% of them went on to become clinical back pain cases, okay, which is higher, significantly higher than the rate in the general population or the people that didn't respond with pain when they were exposed to standing. So what we're saying is this response can become a clinical pathway if it continues to be exposed to standing. So I think a big deal, because now we've linked, not only is it uncomfortable and you don't like it, it becomes a clinical issue in our healthcare system and back pain pain we know persists for a long time. So what do we do about this? Well, being from a kin department, and one of my students at the time was a physiotherapist, we decided to see if we could change people. And it was wonderful. We did a low-level core strengthening program, so it wasn't lifting big weights. It was actually quite innocuous. And over 4 weeks, and what you're looking at as the graph there is our pain developer exercise group is in blue, and you can see we reduced them below that pain level. So they would then be classified as non-pain developers, simply by doing some exercise. The bottom graph just shows you the people that were controlled, that weren't in the exercise, didn't change status. Pain developers stayed pain developers, non-pain developers stayed non-pain developers. Problem with this is, how do you implement it? I have some ideas, but I think it's going back to the idea of you have exercise programs in work, or there has to be something. Because remember, these people aren't identifying. They're not showing up and saying, I have pain from standing. So it can't be reactive. It has to be a proactive solution, and it's hard to identify who you should prescribe this to because they haven't complained about anything yet. So that's the problem with this. I think it's very powerful, and I'm still looking for a nail to hit that hammer with, okay? Because it was great in a study, but I can't see how necessarily to translate it to industry easily. So looking at more viable solutions, simply rotating, right, between standing and sitting, or sitting and walking, or coming up with some kind of solution. And we stumbled upon, this is 3 different studies, and what it's showing you is once that pain starts, doesn't matter if I take a walking break, which is your top left, where you see the dips, they get an immediate reduction in discomfort, but as soon as they go back to sitting, the pain comes back. Okay, the blue is they sat the whole time, the red, they had 2 walking breaks. If you move over to your right, that was a ratio of 3 sitting to 1 standing. And you can see the sitting and standing in isolation for an hour had back pain. So here's another example. I can get back pain in people with sitting. It just doesn't translate to bigger studies. And then the green was if we mix the 2 of them. So same thing, when they would go from sitting to standing, you get a reduction in discomfort, but as soon as they went back to sitting, it was cumulative, like it stacks there. If you kind of, I don't have a pointer, but if you lay a linear line across the tops of those peaks, you can see it continues to go up. And then the bottom was the flip of that, where they stood for 45 minutes and then sat for 15, and the same thing, that it's reducing it, but once that pain starts, it's really hard to get rid of within a shift. Okay. That made us then start looking at posture, what's going on, and all I want to take away from this is you can see pain developers in blue, unfortunately there's a color flip here, had less movements. They're moving less often, right? We want to instill movement. And pain developers were moving less often, non-pain developers more, but they're only different at the beginning, first 15, 30 minutes. What's exciting about this is that's happening before pain's developing. So if you look where they're reporting pain, it's out 30, 45 minutes on your right graph, where that blue line kind of breaks above 10. So they have this pre-existing before they get pain, which to me speaks, we can do something about this, okay? So one of the easy ones is a foot intervention, right? Because it's one of the things we do. We give anti-fatigue matting, we give a foot rest for people to put their foot up on or stand on a sloped surface. So we measured all of these with an x-ray. This was a radiograph study looking at the postures of the lumbar spine. Upright is just level ground. And what, I think I have a fly in here, yeah. And what you can see is by elevating the posture, we can change the posture of pain developers in red in the circle to similar to blue in normal standing postures. So we're inducing a mechanical change in their posture, and then the question is, does it make a difference? Because that's great, right? It's a simple engineering solution. You have back pain, here's a footrest. Done. Where's my paycheck? I'm going home. Okay. So we did a study on this, and the first thing we found in the pilot was people couldn't stand with their foot up for like 20 minutes at a time, right? That induced a whole bunch more pain. So it became short duration. So they would stand level for 3 minutes, raise their right leg for a minute, go go level, go left leg, and it was just oscillating of postures, inducing movement. And what was great is the 2 lines that stay below the red are when they were doing this protocol. The 2 lines that are pain developers above the red were control when they were just standing. So we turned pain developers into non-pain developers. And what came out of it, that noisy graph on your right, is the muscle activation. And you can see now it's following what a non-pain developer looks like. So we've changed posture, and in doing so, it looks like we've mitigated the muscle activity that was linked to that co-contraction as well. The other idea was, because they were different at the beginning, we wanted to induce changes early. Okay, so we came up with this idea of, can we get a pattern changing at the beginning by getting them just moving frequently early, and then they can stand longer later in the shift. Okay. And again, this also worked. So there's very promising changes here. Again, lab studies haven't applied these in the field at this point in time. And you can see that the black line were our pain developers when they were just standing for 2 hours. And the red line is when we induced these changes. And we kept them very similar to non-pain developers. So very exciting, right? But it speaks to the how do you get people using these workstations and training. It's not as simple as just giving somebody a workstation. So we decided to do a field study, which always sounds like a great idea till you're in the middle of it and realize it's not like a lab study where you have all kinds of control to do things. But it was fortunate, the university, like almost all the companies, and I'm sure why some of you are here today, was evaluating, should we be moving to sit-to-stand workstations? So we had one whole unit that was given sit-to-stand workstations. They were moving, so it was a perfect time for a study. We collected baseline in their existing sitting workstations for 4 weeks, had a washout of a week. They got the new workstations. We followed them for 4 weeks with training, and then a follow-up period of 4 weeks where we didn't talk to them anymore. And then we actually snuck in another 6-month checkup that I'll show you some preliminary findings from that they didn't know we were doing. And this was shamelessly built on Michelle's work and others for what is good training, and our own work of implementation of changing musculoskeletal risk by some of the studies we've done. Okay, so industry approach or minimal training, whatever you want to call it, was here's your desk, here's how it works, a little brief overview. So very minimal intervention at the beginning, and that was delivered by an industry supplier. Then what we called best practice, maybe a little arrogant, but at the time we thought it was a good name. We used behavior change techniques, many of the things Dr. Robertson talked about, hands-on demos, as well as having weekly meetings and following up. Okay. And so what happened? Well, good news is we actually, in the intervention phase, implemented a significant change in the number of transitions that use the desk. Okay, so you can see actually more than double the changes. We don't have total time here, and there's a problem that if you want to ask me about it, the panel will talk about, but it's difficult to make quantitative changes. And I want to make that clear. This was measured transitions on their workstation, not asking them if they used them or not. And they didn't know how we were measuring it or what was going on. After the follow-up, so this is 4 weeks of us not talking to them anymore, it persisted. They were still doubling their usage of the workstation compared to the group that were minimally trained that didn't change. The downside is 6 months, 7 months, right, because the 4-week washout plus another 6 months after that, they're still moving them a little bit more, but they're trending down to what the minimally trained group was. So I think the message here is you can't train and forget them either. There has to be some ongoing, refreshing going on, checking in with the users at frequent points, or maybe not frequent, but staying in touch with them. Because it's my interest, I'll show you this as well, that that number I talked about of about 50% of population having low back pain in response to standing. We had this, and these were all like a wide range of people, were real workers, not students in a study in a lab. And you can see that our best practice approach had a significant change in people who are pain developers. The industry approach also reduced it. So it looks like there's potential here. And Dr. Rempel actually talked about he loves his because he has low back pain. I would echo that comment. I have low back pain, and I love my station because I can get into a different posture and not be sitting all the time. And so that kind of fell out as well. And then one of the final points I'll make here, because it's one of the things that are brought up, that having a sit-to-stand workstation will increase activity. We saw it doesn't really change metabolic cost at work, but the idea is because you're doing that, maybe outside work you'll be more active. So we gave them Fitbits and tracked them for 16 weeks or whatever the total was here. And you can see that after they got the workstations, sit-to-stand workstations, their step count actually decreased down. So there certainly could be a little bit of bias there that it was a new Fitbit. When we get them, we all are more active, right? Because we want to see it go up. But it was a 4-week period. It's not a day at different points. These are averages over a month, 3 months consecutively. Okay. All right, so some take-home messages. One is standing is clearly linked to musculoskeletal disorder, reporting, pain development. Sitting's a question mark. We think there's good evidence from a biomechanical perspective. Small studies in controlled, constrained sitting show that there's pain development, but when we get into big ones and don't understand what the sitting exposure is, the evidence isn't as strong. Okay? So I'm trying to soften this because I don't want you to go away and say, Jack Callaghan said sitting doesn't cause low back pain. Not what I'm saying. What I'm saying is there are no big studies linking the amount of exposure to low back pain or sitting and the development of low back pain. Okay. Standing clear, about 50% of people will develop low back pain from standing exposure. One of the things to take away if you're implementing these, it's not a one-size-fits-all, and I think we'll hear from this from our industry panel and our practitioners. You have to treat these ratios and how people stand individually, okay? Things like this low back pain development, prior injury, the type of work they're doing are all factors. I think Michelle described it as the systems approach. You have to think of all these factors when you give it to them. You can't give it to them and say, you should be standing 10 minutes out of every hour, okay? So not a single ratio for everybody. I showed you that standing alone does not reduce low back pain. Based on the standards that are out there, 4 hours should be an upper target to balance, I think, the benefits of maybe some health offset without going too far into standing, because we saw if you stand too much, there's negative health there as well. So we're coming from both sides now, right? Not just saying sitting is bad, standing can be bad too. Maybe, to stick with that theme, standing's the newer smoking. If sitting's the, right? So, and this is what I said in the opening, that we're coming around, that people are now looking at standing much more critically. And there's a long history actually of looking at standing and musculoskeletal disorders and health as well that kind of got forgot about, I think. So my own 2 cents around ratio right now is a target of 1-to-1. I don't think most people will ever get there, but it should never exceed 4 hours for most people. Okay, even if they tolerate it, I think there's still potential for health risks if you're standing too much. Because there are people that will tolerate standing, just like I can sit all day, whether it's good for me or not, I can tolerate it. Big one is once pain has initiated, it's residual or cumulative within that shift. There's not enough longitudinal data to say, does it carry over into a week, etc. But I've showed you that over 3 years, we can turn people who do develop that pain acutely become clinical pain cases, okay? So that led us to the idea that the interventions have to happen early. When somebody shows up at work, you need to get them moving earlier. If they stand until they feel pain, it's too late. You can pretty much write that shift off, is the way I view it. A good analogy is drinking and dehydration, right? When you're working out, if you wait till you're thirsty to drink, it's too late. You're already dehydrated. You have to be drinking before you feel that thirst sensation to drive it. Same thing here. You can't wait for pain to be a trigger to change postures. Exercise, I think, is a wonderful solution. It's good outside work for health as well. The the translation into prevention is hard for me to think of, but I'm happy to talk about that. Driving from the feet, I think, is a very viable solution, but again, it has to be inducing movement. It can't be a static exposure. And we've kind of coined the term of move early, move often to try and prevent these pain development. So I'll leave you with another Onion article that came out. You know it's a hot topic, right? When the media that makes fun of the media start publishing articles. So. And I'll finish there. Thank you.